All right, so it's 11:02. I think people will be trickling in, but let's get started. So I want to welcome everyone to this didactic / mini, very abbreviated workshop called Did That Just Happen? Responding to Microaggressions in the Emergency Department, Individual and Programmatic Interventions. I want to introduce the presenters today. So I'm Danielle Miller. I am the Medical Education Fellow at Stanford Department of Emergency Medicine, but we have a great list of presenters today. We have Dr. Emily Cleveland Manchanda, who is coming from Boston Medical Center and is Director of Equity Initiatives. We have Dr. Anita Chari, who's also coming from Brigham and Women's Mass Gen Hospital, as she's one of the chief residents, who's very involved with DEI there. Dr. Italo Brown, also from Stanford, who's the curriculum lead at the for Stanford on health equity and social justice. Dr. Star Knight, also Director of Diversity and Inclusion at UCSF. And finally, Dr. Meg McGrath, who's the Senior Medical Director in the Department of Emergency Medicine at BMC. Additionally, we have facilitators from many institutions that are listed here. Again, this is a combined effort from BMC, Harvard, Stanford, and UCSF. And these facilitators are going to help with our small group breakout rooms. We have no disclosures.
So it's important for us to set the tone early in this conversation. For everyone that's here today, know that this is a safe space. We are all learning. We're all in the process of uncovering our own biases. And we just ask that there is a bit of grace as we really go through what is potentially a sensitive topic. And also know that the things that we discuss may inadvertently trigger you. We do not intend to cause any harm or any discomfort in this dialogue, but it is, again, important for us to traverse it, and more important, for everybody to feel comfortable in this space.
And the objectives of this talk are describing microaggressions and their negative impact on trainees, identifying real-life examples, and demonstrating how to respond to common microaggressions, and lastly, discussing programmatic initiatives to mitigate microaggressions. The structure of this talk is we're going to do a 20-minute introduction on microaggressions and how to manage microaggressions, a 20-minute kind of small group breakout session where we do a practical exercise in responding to microaggressions, and then the last 10 minutes will be conclusions on programmatic interventions and questions. So let's begin.
Hello, everyone. Let's start off by establishing a foundational knowledge of what microaggressions are. Now, microaggressions have gotten a lot of attention in recent years. In fact, the term microaggressions was coined back in 1969 by Dr. Chester Pierce, a professor of psychiatry and education at Harvard. He used this term to illustrate some of the offensive mechanisms and oppressive acts that Black Americans faced on a daily basis, describing them as acts that were aimed to reduce, dilute, atomize, and encase Black Americans into a hapless place. Since then, there's been an immense amount of work on microaggressions, and Dr. Daryl Wing Su, professor of psychology at Columbia, has an extensive body of work. I in particular like his definition of microaggressions, that being microaggressions described as being brief, everyday exchanges that send denigrating messages to a target group. And the reason why I like this definition is because it emphasizes the micro of microaggressions. Next slide, please. Now, some people think of the micro of microaggressions as solely referring to micro insults or micro offenses that can be subtle and many times unintentional. I want to point out that microaggressions can also be very blatant and can be very targeted, extremely offensive acts of bigotry. When we think about micro in microaggressions, we're really talking about acts that are happening on a daily basis on an interpersonal level between individuals. Macroaggressions don't refer to blatant microaggressions. Macroaggressions refer to these offensive and oppressive acts happening on a systemic or societal level. So examples of macroaggressions throughout history include the African slave trade, apartheid, the prison industrial complex, the system and the ways in which Black and Brown people are policed in the US, the separation of families at the US-Mexico border, just to name a few. The term microaggressions is an all-encompassing term. It's an umbrella term encompassing many of the acts and oppressive acts based on isms and phobias that we are all familiar with, such as racism, sexism, ageism, ableism, xenophobia, homophobia. And as I mentioned, microaggressions have been studied extensively and can be broken into several different categories: verbal, physical, and symbolic. Some of us encounter microaggressions so commonly that we don't identify them as such. For instance, verbal microaggressions, many of which can be backhanded compliments such as, "You speak English so well for a blank person." Or the verbal microaggressions many of my female emergency physician colleagues face on a daily basis while walking through the emergency department, being called out as a nurse, or spending an extensive amount of time with the patient only to have the patient ask when they're going to see the doctor. Similarly, physical microaggressions, those happening with body language and eye contact, happen so commonly. I personally have witnessed being in a room with the patient and watching my patient's gaze and body focus on any male in the room, whether that male is a part of the janitorial staff, an X-ray technician, a medical student, or a nurse. Similarly, I know there are people on this call who have been pregnant and have witnessed touching and physical microaggressions around touching. And although we can all agree that it's important for us to obtain consent before we touch anyone, there is this societal kind of understanding and unfortunate belief that when you see someone's pregnant uterus, there's an invitation to touch that person. I invite you to think of the opposite, meaning walking up to someone who isn't pregnant and trying to touch their non-pregnant uterus. I think we can all agree that would be entirely inappropriate. And lastly, symbolic microaggressions. We are bombarded with visual cues and visual messages in media and in social media on a daily basis. And we could target an entire session simply on that. Next slide.
So oftentimes when we think about discrimination, we think about blatant examples of discrimination that's interpersonal. And here in this slide, we're just going to focus on looking at racial microaggressions. And some of these are examples of interpersonal racism where an individual gets singled out or subjected to a slur or harassment or a joke on the basis of their race. So just looking at all of these examples together, the first two might seem more obviously discriminatory or racist or racially inappropriate, and we could classify those as interpersonal racism. But the bottom three examples are harder to recognize as problematic, they're harder to call out, but they are subtle forms of discrimination. And these are examples of microaggressions, giving you a few more here, part of a daily experience that can be exhausting. Next slide, please. An important point about microaggressions is versus impact. So when we look at these examples of microaggressions, we can easily imagine how the speaker might have had benign intentions without any desire to offend else. But we also really have to think about what is the person who is hearing this comment, what are they hearing? Again, remembering that microaggressions are common, it's really not just this isolated incident, it's taken together as part of a cumulative experience. So if we look at the first one, wow, articulate, the speaker of that might be intending to compliment. However, what the person who is addressed with that comment might hear is, "I don't expect people of your race to be eloquent or to speak well." And this is, "Wow, you're so articulate," is a comment that's often made to Black and Hispanic physicians, whether it's by colleagues or patients. And the underlying assumption is that I wouldn't expect you to be able to speak well or professionally. Or if we take the next example, "You don't look like you speak Spanish." Somebody might be intending to convey curiosity about another person's background. But again, thinking about what the other person hears, what they might be hearing is an implicit assumption that all Spanish speakers look alike, or that everybody who is Spanish speaking is dark-skinned. And then taking a look at this third example, a very common question that we get in medicine from patients and colleagues: "Where are you from?" But no, really, where are your ancestors from? So again, here, the speaker might be intending to convey curiosity about someone's heritage, but what you hear is this assumption that, or an implicit understanding that you're not American. We'll advance to the next slide. And again, this is where it's crucial to really think about that distinction between intentions, which can be good, and impact, which can be unfortunately negative. So we suggest thinking about the impact of an unintended microaggression in the same way that you would think about a medication error. So say that a physician means to order Lovenox, but accidentally orders Levemir, and the patient becomes hypoglycemic. Harm still results. And when a experience at work is full of things like where are you from, or your name is so confusing, or having people ask to see their ID, each time that person experiences a microaggression, even if you think it's something small that they should be able to off, it's part of a cumulative experience that can be very impactful. And just to think about impact, we just wanted to emphasize that the impact of microaggressions really extends beyond personal offense. Microaggressions lead to negative psychological effects, things like self-doubt, frustration, and isolation, mood issues like anxiety and depression. Those can lead to bad coping mechanisms such as alcohol use or drug use. And microaggressions have also associated with burnout and even hypertension.
So it's important, I think, to also consider why we don't always speak up when we hear a microaggression or witness a microaggression as a bystander. Our social interaction rules and sort of the way in which we are socialized in society typically discourage confrontation. And that's even more so on teams where hierarchies are at play. So understanding that there are power dynamics, particularly in the medical profession, is really important when we think about how and when we choose to address microaggressions. There's also lots of hesitancy about saying the wrong thing, and that's particularly true when we're talking about race, because in the US, we've been conditioned to at least pretend to be colorblind, and oftentimes are very hesitant to discuss racism head on. It can be challenging to intervene or speak up when we witness a microaggression, or we can feel disempowered and then sometimes feel complicit in those microaggressions because of this interplay between a couple of different tensions. We're always interested in facilitating clinical care and wanting to just continue the care for the patient and sort of move past whatever might have happened. And we also often, I think, feel the need to maintain professional relationships. So particularly if we hear something that a colleague has said that is perhaps problematic, it can be really challenging to speak up when you're hoping to maintain those relationships, regardless of where you fall in that power hierarchy. Similarly, there's often a tension about needing to advocate for your patient that's at play. And if the patient is themselves either a victim of a microaggression or someone perpetrating them, it can be really challenging to sort of navigate that relationship as well.
We surveyed faculty in our institution last year and learned it's really hard to speak up about this. People feel like a deer in the headlights, they're confused, don't know what to say. And many people regretted that they didn't say anything at the time, aware that by not saying something, they're saying something, and that their silence can be interpreted as condoning what just happened or what was just said. We also know that every episode's different and may call for different types of responses. So we created this mnemonic LIFT to try to be a tool to give people a place to start with trying to know how to respond. The L here stands for lights on, shedding light on what just happened. Did I hear you say, did you mean to say, or I'm surprised to hear you say that, just shining a light on what just occurred. The I stands for impact from intent. And this is letting someone sort of distance a bit from it. Maybe you meant that to be funny, but it wasn't funny to me. I'm sure you were trying to make a joke, but that didn't land right with me. F stands for full stop. And that's when we just, sometimes things are said that go way too far and we just have to put a stop to it. So ouch, time out, hang on, that went too far for me. And then finally, T stands for teach, which is the idea of helping others along. So I used to think that way until I learned, or I've started using different language now because I've learned about stigma and how harmful that can be, just sort of trying to help teach each other about this. Again, we need to develop our own responses, things that feel authentic and comfortable to ourselves. The LIFT mnemonic is meant to give us a place to start.
In addition to the LIFT mnemonic, there are some responses that you can keep just in your back pocket and utilize if you happen to have a little bit of a struggle in starting that conversation. One that I really like is the direct response and saying, what did you mean by that? And asking it in a way that is open and truly gives the responder a chance to explain or rather give details about how they meant. You can call someone in or call someone out. Calling them in sounds something like, can we talk about what just happened? And then engaging in a conversation around the incident or the circumstances. Calling someone out strictly saying, hey, that's not cool. We have to do better, or inquiring more about it. Like, that doesn't feel like a joke, and I don't find it that funny. The one that I think is most profound here is allowing for space to reflect, making sure that you give someone the chance to think about it by saying, I'm surprised to hear you say that. And then following that is the self-reflection. The main thing is using these responses may feel canned, but it's important to own them and tailor them to yourself. Next slide.
So we're going to invite you to, we're going to move on to the second portion of our workshop and invite each of you to participate in skill building. We ask that you turn your cameras on and unmute yourself during these exercises. And we encourage you to approach this similar to any other continuing medical education or skill building session, meaning that these types of skills are equally important and as equally important as learning how to put in a central line correctly or learning how to give appropriate feedback to a learner. So we invite each of you into small group sessions where we will go into skill building based upon clinical vignettes that are personal to many people on the panel and common to the experience of many emergency physicians.
Excellent. So I'm going to send you to the breakout rooms. And if you have any issues, please feel free to come back to the main room.
And you'll see an example of some of those back pocket responses listed in the chat.
Apologies. I'm just going to make sure that this goes into the right mode for me.
Kristen, this will be a great interactive experience for all of us.
Well, forgive me for sitting outside. This is the first sunny day in a week, and I couldn't resist.
I love
If the
it.
dogs are barking, I'll move inside.
Totally. I love it. Good for you.
There we go.
And by the way, I think this is going tremendously well. I've been on some of the sessions this morning. I'm so impressed. Everybody's doing a great job.
Thank you. That's very kind of you.
That's great to hear. So maybe we could take a quick moment to just say all of our names and kind of where we are. I'll start and say that I'm Anita. I am a PGY4 resident at Mass General Hospital and the Brigham, and I'm one of the group.
Okay, I'll go next. I'm Kristen Nordenholtz from University of Colorado, and I am one of the faculty, and I'm trying to learn something. Thank you.
Hi, Kristen and Anita. Nice to see you. I'm a faculty member at the Brigham and Women's Hospital, where Anita Chari is the amazing chief resident. And I'm delighted to help facilitate the workshop and have done so at our institution.
And I'm L.A. Alvarez. I'm one of the associate PD here at Stanford, and I'm super excited to be part of this group. Melissa, you're it. Oh, or not. Scared her. And Doug is part of the SAM, and he's trying to help us organize a lot of these talks.
So to start out, the whole point of this second session, which is about 20 minutes, is to go through some cases and kind of think through how we would respond to them. So to just show the lift mnemonic again, if this is the mnemonic you prefer, again, the first is lights on. So we're trying to make the invisible visible by sort of pausing and saying, did you mean to say X, Y, or Z? Or I'm surprised to hear you say that. The second component is really considering that impact versus intent and making that clear. I think you might have meant to say X, but ... The F is for full stop, really taking that time out to express that you don't agree or something is wrong about the situation. And then the T is for teach. So making that underlying implicit assumption explicit and kind of helping people understand why a comment or behavior might be perceived with a negative impact. So this was the lift mnemonic. I believe it should be in the chat. It was sent out right before we headed into the break rooms. And then this was the backup pocket responses to try. So direct questions, assuming best intent, calling someone into conversation, calling someone out and identifying a behavior as inappropriate, dispelling the idea that something's just a joke, being honest, showing curiosity, acknowledging that something is wrong, and allowing for space to reflect. So I know that's quite a bit, and we can certainly go back and forth with the slides, but the hope was that we would get through a few cases as a group. And this is all kind of group discussion. So we'll start out. Our cases are numbered out of order because we chose the cases that we liked the best. So those are at the front. So I will turn it over to Val or LA. We can go through this case and then kind of talk about how we might respond.
So this is a common one. We chose this because this is said probably every day. And the understanding of the impact is not quite clear as we say that. I say we because the first thing we ought to say is we all commit these microaggressions. These can be unintentional and we're not aware of it. So here's an example. An attending to a medical student who might be rotating. Where are you from? And the student says, Connecticut. Attending, but where are you really from? The student, my family is from Colombia, but I live here now. Attending, wow, you are from Colombia. I wouldn't have guessed it. You are so well spoken. That has a couple in there. The where are you from, where are you from? And also about the ability to speak and articulate well. So this to the group, and Kristen, if you have some thoughts, not to put you on the hot seat, even though you're in the warm sun, I guess that's appropriate for you to be on the hot seat.
I love it.
Since you're warming up there in the Colorado sunshine, if you recognize this and what are ways in which you might want to address this, and we're here to help to talk about this.
Well, sure. First of all, I'm guilty of this. I probably did this about 3 days ago, meaning it in a very well-intentioned way because I was actually really curious where the person came from and what their heritage was, and I wanted to learn more about them. So that was the intent, but I've definitely committed this. But I'm just curious, the microaggressions you're talking about yet a third person intervening, or are you talking about one of the two people involved in the conversation navigating the microaggression?
Well, there's two components. There's the target, if it's the student, how they might respond, but you as a witness is what I'd say. Either you as the perpetrator or you as a witness to another attending saying this, or you actually being the perpetrator of saying that. Like I said, we are all guilty of it. We have all said these things. I want to just start off that way. An awareness that this over time, this poor student 50 million times a day, where are you from, to feel other, like alien in your own land. So that's the point. It's not a one-off. It's like every single day, every new attending. So Kristen, so it's a matter of either you have said it and they may respond like, why are you asking? I'm curious. That might be their response as a target to you. Dr. Nordenholtz, I'm curious, why are you asking me that? And how might you respond?
So can I address it as the third person watching this? So I would then say, I think that's a really interesting question. I know you're very well intentioned, but it might feel, I'm having trouble with word finding right now. It might feel a little discriminating the way that you phrased it, or I'm not that familiar with this. I'm going to have to admit I'm very bad at this, so I'm trying to learn. I know you didn't mean it that way, but it came across as, right?
I love that, and I do want to acknowledge as well, like this should be uncomfortable, right? If this is so easy, then there won't be workshops like this. And so like I'm really glad that you're able to say that, because I myself would be fumbling with like, oh crap, like what do I say next? And hopefully by practicing this in this space, like a safe space, then we'll be able to kind of more automatically respond to it when it does happen in front of us. So I do like that.
And absolutely, and you're assuming best intent, which is one of them.
Yeah.
It didn't mean harm. This was an unintentional curiosity. And so you assume best intent is kind of one of the mechanisms, but you also are saying what the impact might be. And so finding those words, I know that you were, trying to be curious about their background, but, that's the impact, to try and say, but that may make them feel like they're somehow, not belonging here or somehow other than most other students. And so we don't, and you can say, we always don't, we may not realize the cumulative effect of those kind of comments are. I've made that mistake myself and I'm getting better. That's the teach of the.
Yeah, I love how you actually covered like the teach there by explaining that. I also love the impact versus intent. And I also like how you, especially in this conversation, you turn the lights on, right? So did you mean to say, or I heard you, or I'm surprised to hear what you said, and then you went on with the intent versus impact. I love that.
And we didn't do the full stop, like, ouch. Otherwise we would have gotten, I'm so.
Exactly.
I wanted all of the lift, but I didn't, but it wasn't so harmful. And it wasn't like when it's really bad is the full stop. Like, that's
Yeah,
the day.
exactly.
Setting boundaries and like, that's really, you can't, that's a calling somebody out in a setting boundaries, sort of more, there's a spectrum, right, of ways in which you can address this. And that's a little more definitive and setting boundaries and on a different level.
I love that.
So can I just jump in and ask, so we have a resident whose Spanish is magnificent, and that came out the other day that I worked with him, and I didn't know that. And so I wanted to say something surrounding that, but I was very afraid of saying the wrong thing. So I actually didn't say anything, but I would have liked to acknowledge that his fluency in both languages is stunning. I had no idea. So how do I navigate that? Like, what would be a good way to say that?
That I think just an observation of facts, and I think just acknowledging someone's fluency is okay. Like noticing a skill or something, I think it's okay, and I don't think can be harmful. But just I noticed that your language fluency is quite good. Thank you for caring for the patient, or being, appreciate your fluency. And if they volunteer or want to share, oh, I spent a year in Peru, or I was in the Peace Corps, or, I think it opens the invitation. But I don't know, I'm open to others, but just an acknowledgement. Well, I just noticed your fluency is extremely, and I really appreciate it in the care that you render to that patient. And that's it. And then they can volunteer or open up if they want to. I think it's just a nice way to invite them or not.
Yeah, and I think it depends too on your personality and how you handle vulnerability. Like, I love, like, for me, when that happens, I do say, like, I feel really awkward about this, but I just want to say that was really awesome that you talked to the patient in Spanish. And I know that sometimes this can be misconstrued as a negative, but I just want to say, like, really from my perspective, it really helped a lot with that conversation with the patient, because he or she felt much more relaxed with us. And so thank you. And so again, like similar to what Valerie said, it's more of focusing on the skills and not necessarily, and also coming in with curiosity. And I think it's okay to fumble, but be quick to realize, like, oh, I did not mean that, or at least be able to acknowledge how much discomfort we're experiencing when we go through these conversations.
Yeah, and Anita, do you have a perspective on that?
I think so much of our interactions are context dependent. And so I agree with expressing appreciation for a skill. And then you can sort of take a pause there and allow, I think, as we've spoken about, sort of allow someone to open up.
Yeah.
But also you can read, I think oftentimes we can read the situation of, oh no, it seems like this person is getting this sort of a comment all the time, and the way that they reacted. And so just when you're about to express appreciation, just sort of also understanding that even as an ally, you may not be recognized as an ally.
Yeah.
Even if things are coming from the best place, it may not be recognized as coming from the best place.
Exactly.
Hi, Judy. Thanks for joining us.
Yeah, I'm hopping between sessions, so I apologize for joining in the middle.
Love it. Thank you.
I know where you just were, so I know which session you're helping.
Should we try a next case? Awesome.
So we're sharing, Judy, cases on our approach.
Yeah. I've actually done this training at BMC, so I'm kind of familiar with the cases.
Oh, cool.
So
So this case is a new physician uses a wheelchair. You overhear one of your colleagues say to them, wow, you're wheelchair bound and you went to medical school? You're amazing. What would you say if you overheard that comment?
So I think in many cases, it depends on what forum you're in and who the person is who made the comment. I think this comment is interesting because they obviously don't mean anything derogatory, or they don't mean they don't mean this as a microaggression. However, you can see how the person who gets this comment many times over and over again might see this as a microaggression. And I think I would approach it by, and this is a good question, but I think I would approach it by, it depends. If we're in a whole big group, I don't think I would approach it with the individual person. But if we're in a smaller group, you might just kind of reinforce that. Yeah, I'm not sure exactly what I would say in this case, because you don't want to add to the microaggression and you don't want to make the person feel badly who didn't mean to make a microaggression.
And this is an example of an ableism comment, right? And view, but that person who's getting it, Judy, you're exactly right. The microaggression is the person, is the target who's getting them, right? And so it's their perception of these things.
I like that, I think, framing as well. I think we do have to acknowledge that this is the reason why it's called microaggression. They're subtle. Intent can be blurry, or at least the impacts can be blurry depending on which context, versus a macroaggression or just overt bias, or racism or ableism. And so I think when we hear something like this, like, it's also important, as Judy mentioned, like, you don't want to embarrass the other person who meant well. However, I think if you hear this and it rings like a little bit like glaring, it might be an opportunity for us to use in that lift mnemonic to do the full stop, like, oh, time out. And then for me, what I'm comfortable with saying is like, you're probably hearing this a lot. And so like just shining light to that fact, that to that new physician, that like you're probably hearing this a lot, and I bet it's probably not as fun to hear it, so that there's an education going on. And then maybe like how might we conversation, how might we honor your work while at the same time not like putting a spotlight to you being in a wheelchair every single time you show up here, because I'm sure you have so many other amazing talent and skills that is more than just being able to carry yourself on a wheelchair or something to that effect. But I think being vulnerable, being able to acknowledge what that other person is experiencing can be important.
I like that comment. You probably hear that a lot. I mean, because that kind of makes the person who made the comment say, oh, wow, yeah.
So this depends on kind of our own personalities, and
Yeah.
I'm someone who's a bit less, I sort of try to avoid confrontation. So I think for me personally, the way I might approach the situation is by both speaking to the target of the comment and approaching them separately. And then one thing that we've sort of emphasized in our sessions is to name your own feelings. So don't make assumptions about how the other person feels or reacts to a comment, but you might say, that comment made me feel uncomfortable. I wanted to check about how you're feeling. I assume you might actually get this sort of comment a lot. So I might have that separate interaction, and then I might try to pull the other person aside. And having actually sort of been in this situation myself, I think when we're in medical school, we learn to read charts that say X and Y patient is wheelchair bound. And so I didn't realize until I started residency that is actually not terminology that the ability rights community favors. And so people prefer to say someone is a wheelchair user than saying that they're wheelchair bound. And so for me, I think the less threatening thing to do in terms of thinking through the lift mnemonic and the lights on and the teach part especially is establish a common ground of, hey, a few years ago, I didn't know this when I was starting residency. But I one time used the phrase wheelchair bound, and somebody educated me that that's actually not the preferred language. And so if you can establish that common ground, I think that also helps make it a little bit less threatening.
I love that.
I struggle with the same thing, whether I think there's a certain strength in approaching it right in front of that other person, but it definitely makes things less comfortable.
So just like the last case, what would be a good way of acknowledging that it may be extra hard for some? In other words, that I am impressed that somebody is managing to do this job in this situation. And because this came up, actually, we had this case also, by the way, last month. And one of the patients said to me in front of the student, the wheelchair using student, wow, it must be, wow, it's amazing. The patient said this basically. And so I stood there like, uh-oh, I'm the attending in the room and I have absolutely no idea what to say. So,
Yeah.
because the patient was truly giving the student a big compliment about what a great student she was. And I truly had no idea what to do next. So I just kept going, do you have chest pain?
No, and it's an interesting thing. I like the assume best intent always. Like, I know you meant to, really to compliment, and then I use a micro affirmation. Like, that's my favorite, that you were complimentary of, doctor, or if it's a student, X, Y, and Z, they're an extraordinary, medical student in and of themselves, and not relying, discussing that, but somehow affirming them in their, I know that you meant, but, regardless, this is, is an exemplary medical student in their own right.
Yeah. What I learned here in our conversations today is that there is a power in individualizing it to that person. So what I learned from Anita, for instance, is I'll just go to that medical student later on and say like, hey, I can only, like, this is how I felt when I heard that. I just want to check in with you. How are you doing? Because I'm not going to make any assumptions. You're probably, whether you hear this a lot, but I just want to make sure that that I noticed that. And also separately talking to the patient and say, again, like just with the patient, without anybody else in the crowd, and say, I'm sure you meant that really, really well. I just want to let you know sometimes the impact of that is XYZ.
There's no right and wrong.
Yeah.
We're all trying.
All right, great. As we're coming back together, I'll have Emily pull up the slides again, and Italo, I think, will lead us off. Or I guess lead off the conclusion.
Undo. I was on mute for a second. That was really a good session, you all. I think that we've got to acknowledge how, what I would say is there's not enough time to have these conversations. It feels like it's as though everybody is making salient points and has experienced these things before, but we have to get better at making this a routine, a regular activity. So in this last 10 minutes, what we're going to do is come back together. We're going to talk about some programmatic and institutional interventions that can be implemented at your workplaces to hopefully reduce microaggressions. We can go to the next slide. Okay, so there's 4 main areas that we'll talk about today. One would be the creation and initiation of tracking reporting systems. 2 will be the development of workshops. 3 will be revising hiring practices. And 4 is designing codes of conduct, okay, in your emergency departments. Go to the next slide. All right. So the importance of tracking systems is essentially to have an institution-wide mechanism where you can have all different incidences being recorded. And we've seen this done successfully in a few different situations. I think that it's written about by the University of Minnesota. We'll see in UCSF. But the main goal is to have a standardized way to capture incidents of microaggression that also protects the identity of those who have experienced it and allows for some sort of didactic training around that. As these incidences occur and as we become more conscious to them, tracking mechanisms are going to be your way of seeing if the department is improving, if you're actually getting better at recognizing and dispelling some of these microaggressions. I think that surveys are great. Questionnaires are fantastic. And also giving reports of how we're doing regularly is important. Then there's the second slide. All right, so workshops, the hope is once you have a baseline understanding of what microaggressions are, it needs to be spread throughout the department. So that means training faculty to not only understand the definition and the language of microaggressions, but recognizing them when they happen, knowing how to respond as an upstander is important. And it should go from top faculty and your executive staff all the way down to residents if you have residents at your shop. The hope is that there's a culture shift by developing these workshops, making them regular, revising them, getting feedback on how they change people's perspective around what microaggressions are, and then eventually making it a comfortable norm for people to call out microaggressions in real time. Simulating this helps. Doing exactly what we did over these didactic sessions where you're going through case vignettes is another way of helping other people understand the importance of microaggressions through workshops. Okay, we can go to the next slide.
Another important initiative is to revise hiring practices. So we know that increasing diversity and inclusion, especially in medical, academic medicine and community medicine leadership positions, helps to promote a variety of perspectives and create environments that are welcoming to all. We also know that the number of underrepresented minorities and women in leadership positions is quite low, and this just diminishes as academic rank increases. What also is interesting is there's been some studies that basically show, that underrepresented groups and women are much better at recognizing, like, say, gender microaggressions or other microaggressions than people that are not included in those groups. And so in a sense, promoting diversity in leadership might improve kind of recognition of microaggressions that would lead to implementation of institutional policies and culture change. And lastly, designing codes of conduct is a great way to kind of mitigate microaggressions on a departmental level and potentially on a programmatic level. This is an example from Mass Gen where they have a Bill of Rights, and you can see there's patient rights and patient responsibilities and a code of conduct for patients, families, and visitors so that they can ensure like the safety of everyone in the hospital.
Great, so we're gonna wrap up and actually finish just a couple minutes early so you have time for a break before your jam-packed next session in your day, your afternoon. We wanted to thank you all for joining us, for participating in this workshop, and for really bringing your honesty and your energy to developing strategies to address microaggressions. One of the biggest challenges in creating a more inclusive work environment for all of us is recognizing when these occur and then finding the words to address each of these microaggressions while still maintaining our relationships with the people around us. I think as we have highlighted here today, seeing the microaggression, hearing the microaggression, and recognizing it as such is the first step, but then understanding how to respond is really equally important because silence can be complicity. And so we hope that you've gained some skills in addressing microaggressions. We hope you've had a chance to practice having the words actually come out of your mouth and that you'll be able to lean on some of these responses and some of the practice that you've had today the next time this happens. And even if your response is just locking eyes with someone else in the room, raising eyebrows and being like, whoa, I just heard that, did you just hear that? That unto itself can be a form of support and sort of alliance building to say that like something happened, it was problematic, I recognize it, I'm here for you. But better yet, to open your mouth, be an upstander, and really address these head on to create a more inclusive environment in our workspaces. So thank you so much for your time, for your energy. If you have any questions or comments, we are all here for you to reach out to in the future. We have a bunch of references, which I'll just leave up here for you to enjoy. Thank you all very much for your participation today.
And I just want to recognize how people are attacking Kira's question. I appreciate that.
Thanks everybody for being here. It was great.
Thanks so much.
Thank you.